Honourable Ministers, distinguished colleagues, welcome to the afternoon session. We're going to try to complete this session by 3 p.m, so we'll move straight into proceedings. My name's Bill Summerskill. I'm an editor at The Lancet, and it's a pleasure to be here with you. Particularly, can you hear? Right. Particularly as we have such an exciting opportunity before us. Inspired by Japan, informed by WHO, and encouraged by the World Bank Group to make universal health coverage a reality. So how can this vision be most effectively translated to maximize health and development across populations and health systems? This morning, we heard that results inform decision-making. But which results provide the evidence needed to make better decisions for inclusive and sustainable universal health coverage? To address these questions, we now hear from Dr. Thies Boerma from WHO and Dr. Tim Evans from the World Bank Group.
Thanks very much, Bill, and I hope everybody had a good lunch. And this presentation is, we hope, will not provoke indigestion, but at the same time, we hope it won't provoke bilateral ptosis, which is a very common condition postprandially when the eyelids start to close as you're enjoying the digestion of your lunch. We've been working since a high-level ministerial meeting held in February earlier this year, in which ministers of finance and ministers of health who met in Geneva requested WHO and the World Bank to develop a framework and measures for monitoring progress towards universal health coverage. And so together with my colleagues at WHO and the World Bank, we've been moving that forward, and today we're providing the first discussion paper on this issue, which has been circulated to you. The point of our presentation is just to walk you through the thinking and the content of that paper. The presentation will give you some sense of the process we've been through in the last 6 months or so. Focus on definition and principles, that came up yesterday as being important. I'll hand over the hard stuff to my colleague Thies, who will deal with methods issues, and then we'll discuss the global and country monitoring. In terms of the process, as I said, we have been working on this in a concerted way, but we've had a lot of consultation thus far. And this has been informal through the regular work that we do with our constituents, but we also have had a number of more technical meetings in various places over the last 6 months, or 2 years really. Ongoing work, this sort of more global effort is being complemented by work in 14 countries where efforts to do country monitoring and measurement of universal health coverage are ongoing, and those are going to be published in a journal, the PLOS Medicine Journal, early next year. We've just placed this discussion paper that you've received on the web, and it will be available for consultation over the next couple of months, and that will be supplemented by further consultations that we organize to get inputs, and we hope to have a revised version of the measurement framework by mid-March. So just to begin, very importantly, this is review for many, but important, as we stated yesterday, to make it clear what it is we're talking about. So the definition that all people who need healthcare services receive them without undue financial hardship, and that the framework that was originally developed by Reinhard Buss and adapted and adopted in the 2010 World Health Report identifies 3 axes along which we think conceptually about universal health coverage: the full spectrum of quality health services according to need, financial protection from direct payment for health services when they're consumed, and then coverage of the entire population. The framework that we developed has really trying to bring global and country perspectives together. And this relates to, on the right-hand side, recognizing from a country perspective that there's no one-size-fits-all approach, that we need to have an ability to have indicators that are appropriate to context and the progressive realization of UHC, and that monitoring of UHC is aligned with other processes of review in country related to the overall health system. But from a global perspective, there is a public goods dimension here, which is if we do set the standards and if we do define the principles clearly upon which measurement can be made, then it helps countries move more quickly to establishing and tailoring their own measures. And therefore, we've really tried to push on the front of a common set of targets and indicators and regular standardized reporting on those common indicators. The principles for the framework are first that it comprehensively responds to the concept of universal health coverage, and therefore we've identified 2 interrelated but separate measures. The first is essential health services coverage for the population, and the second is financial protection coverage for the population. So these 2 dimensions require measurement. The second principle is that we encompass the full population in our measurement across the life cycle. And this means not only focusing on mothers and children or the young, but recognizing the life course, the age and gender groups that are necessary to encompass the full population. Third principle is that we capture the entire health system, all levels of the health system, not just the front line, not just tertiary care. It is the entire health system that constitutes universal health coverage. And the fourth principle is that we explicitly identify the need for disaggregation across stratifiers of inequity that are commonly found in all countries. And this relates to socioeconomic status and other factors such as gender, age group, place of residence, which are frequently found to stratify inequitably health outcomes. We very deliberately wanted to place this measurement framework in the post-2015 development agenda context, because that is really what's being discussed from a global perspective. We have been participating in that process thus far. Health will definitely be part of the development goals, and within the health envelope, we've identified in the high-level panel report that there's an effort or a priority in the post-2015 context to accelerate the MDG agenda to begin to tackle and reduce the burden of non-communicable diseases and to ensure universal health coverage. In addition, though, we think that the UHC as a goal in health is very good because it correlates or relates very closely or centrally to the broader development goal of eliminating extreme poverty. We know that financial protection will decrease the number of people impoverished due to healthcare expenditure. We know that's a big number. But we also know that coverage of health services helps people learn and become productive or remain productive members of society and therefore contribute to the economy. Secondly, we want to recognize and acknowledge, as I said this morning, the growing demand for universal health coverage coming from countries and the need to articulate this more prominently as a comprehensive objective of health systems in contrast to some of the more specific targeted disease priorities. Thirdly, that we want the measure to be sensitive to the priority groups of health conditions that are already part of the discourse. One is the MDGs and the unfinished agenda, which is a primarily maternal child health focus. But secondly, the newer agenda of chronic conditions and injuries. And you'll note we're not saying NCDs because we think we need to think about non-communicable diseases, but also mental health, cancers, and injuries. But these conditions mainly affect adolescents, adults, and the elderly. And you can see that through these two conditions, we get that full life course coverage, which is one of our principles. The consensus furthering our sort of focus on this is that the MDGs and chronic conditions and injuries already have considerable consensus with respect to the indicators that should be measured for coverage of the key interventions to achieve results in those areas. And so we're building on well-established consensual indicators as opposed to trying to develop de novo, a new set of measures. And finally, the principle of hardwiring equity into all targets, very clearly articulated in the high-level panel report, and in this, in our measures, we'll reflect that as well. So now I'm going to hand over to Ties, who's going to walk you through the methods.
Thank you, Tim. So I'll start with the first component, the intervention and service coverage. And as we all know, there are many possible interventions for countries to monitor. Universal health coverage is about progressive realization, so intervention areas and interventions are added as more becomes possible. We also know that there are many coverage and risk factor reduction indicators. Just to mention an example, the Countdown 2015 for maternal, newborn and child health has about 25 coverage indicators. The Commission on Information and Accountability came up with 8 coverage indicators. The UNGAS monitoring plan after 2011 for HIV has 20 indicators, of which 20 coverage indicators out of the 29. The NCD political declaration action plan has 9 voluntary targets and 25 indicators, of most of which are risk factor reduction and coverage indicators. And the World Health Assembly has, in its resolutions in the past 10 years, specifics about 100 indicators, 50 of which have targets, and many of those are coverage indicators. So there's definitely no shortage of indicators, but there are also many gaps, particularly for treatment. So we identified a set of criteria for selection of indicators. In the end, no indicator is completely perfect, and there has to be some kind of trade-off. These criteria can be summarized. There are about 8 or 9 or so as the relevance of the indicator, addresses a health priority, is a cost-effective intervention, the quality dimension of it, often referred to as effective coverage, so there is also a quality of the implementation of the intervention component in it, and then the availability of the indicator around standard methods, good data about numerator and denominator, possible to measure it regularly, and disaggregation. Now, in order to sort of structurally approach this and these thousands of indicators that are actually there, we use this schematic presentation, basically starting with the full spectrum of interventions addressing health needs in the population, and grouping them, as Tim said, into communicable, maternal, perinatal, and nutritional conditions, or health MDGs as we call them, and then the non-communicable diseases, mental health and injuries, the chronic conditions and injuries. And then within each, distinguish between promotion and prevention intervention areas and treatment and care intervention areas. So like family planning, pregnancy care, nutrition, HIV prevention, all the way on the left, and the health MDGs, prevention and promotion, all the way on the right, things like treatment of non-communicable diseases, mental health conditions, injuries, etc. And for each of those intervention areas, try to find appropriate indicators of the coverage of the intervention among the population in need, with equity and ideally quality components. So some examples of indicators that perform relatively well in the MDG group, indicators like antenatal care, 4 or more visits, skilled birth attendance, child immunization, family planning needs satisfied, antiretroviral therapy coverage, TB treatment coverage, bed net coverage for malaria. There are a number of indicators that, of course, are now very central in monitoring the MDGs that need to be continued. Under chronic conditions and injuries, there are a number of risk factors which as a coverage indicator, we then translate into the opposite. So it's not tobacco use, but non-use of tobacco in the population. And there are also 3 indicators that stand out as potentially very good because one can measure effective coverage: hypertension treatment, diabetes treatment, and vision correction, because one can measure the status of the need in the population through surveys. The big challenge is that treatment indicators are very difficult to measure because it's very difficult to determine population need. And these are the kind of interventions where the risk of catastrophic health expenses due to out-of-pocket expenses are greater. One is the treatment of acute illnesses in children like diarrhea and pneumonia. Recent validation studies have really shown that the indicators that we use are unfortunately not all that good. But also for treatment of chronic conditions such as angina, depression, chronic respiratory disease, we don't really have biomarkers that we can use in household surveys or otherwise to determine the need. And we cannot ask questions like, do you have depression or do you have angina, because it's really about trying to find those people who are not met by the services. It gets even more complicated when we think about the higher cost interventions, if we think about surgical treatments like cardiac revascularization procedures, hip replacement, cataract surgery, etc. And it's quite illustrative to see that the OECD monitors the coverage. Actually, they don't monitor the coverage of these procedures, but basically just present the occurrence of these interventions in the population. And Mark may want to comment on that. Very critical if we think about coverage, service coverage indicators, is how do we communicate this information to policymakers? So if we do the elevator test here, we get a bit of a dilemma. Can we use a composite measure? So, Minister, the coverage for MDG has gone up from 60 to 80%, and the chronic conditions and injuries from 50 to 60%. The question that you'll get back is, well, what's actually in it? How was it computed? Maybe we should use a few tracer indicators. Skilled birth attendance went up from 60 to 80%, and diabetes treatment from 30 to 60%. Yes, but what about all the other indicators? Or, as we see, we have a multitude of indicators that need to be monitored to track progress, but rattling them all off, we will not get done before we reach the top floor where the minister exits, and we haven't given any message. So it is a dilemma, but we do think that somehow we got to have meaningful, transparent, composite measures of service coverage that, for both group of interventions, MDGs and chronic conditions and injuries, that also take into account the broad age groups, mothers, children, adults, elderly, the different levels of the health system, ambulatory, population, and facility-based interventions, and have transparent ways of weighting, equal or unequal. So that's about service coverage. Then about financial protection coverage, it is a little bit simpler in terms of the number of indicators. So there are two indicators being proposed: incidence of catastrophic out-of-pocket spending, that is the spending exceeding a threshold of the household's ability to pay, and the incidence of impoverishment arising from out-of-pocket spending. Now, again, to make it a sort of coverage measure, they have to be rescaled to 100%. So 100% is the target, meaning no catastrophic expenditure, no impoverishing payments. Then about the third dimension, the equity measures. So universal health coverage is fundamentally about equity, all people getting the services they need and all people protected from financial risks. Equity measures for service coverage and financial risk protection can focus on the poorest 40%, the shared prosperity goal that the World Bank group has proposed, and that could be a cross-cutting measure globally. We could also, of course, at the country level, it's very important to recognize the many other dimensions that are important. So in terms of targets, service coverage, 80-40, meaning 80% service coverage among the poorest 40%. For financial risk protection, zero financial risks, meaning 100% financial risk protection from catastrophic and impoverishing expenditures. So these would be targets by 2030, but as we heard this morning from the President of the World Bank, it would be good to also set intermediate targets by 2020. So I'll hand over to Tim again.
Thanks, Keith. So we thought it would be important to develop some illustrations of what these measures might look like, and so we're just providing two illustrations using a data set that is very amenable to this sort of analysis and these sorts of measures, but perhaps isn't the most reliable data set in the world, and therefore not the one we're recommending that be used to measure and monitor progress moving forward. But it works very well for illustrative purposes of the measures. And so what we've done with the World Health Survey data from 2002-2003 is we've looked and clustered the MDG and chronic condition and injury coverage indicators that were in that survey. And here we've looked at the levels of coverage that you get organized by World Bank region, which is roughly analogous to the WHO regions. And what you can see in both of these is if you look at the MDG coverage, first you can see the red dotted line is the 80% coverage threshold. That's the target. And you can see that both in aggregate and for the poorest 40% for the MDGs, they're below the target in terms of the coverage. And for the poor that are in the poorest 40%, who are the lightly shaded blue bar, you can see they consistently have lower coverage than the population as a whole. So you can see that these measures reflect what you might expect in terms of the inequities in coverage that are found in virtually all countries in the world. If we look over to the chronic condition and injuries, you see a similar pattern with respect to the average whole population coverage and the poorest 40%. But in contrast to the MDGs, you can see that the coverage levels are much lower. And again, this corresponds with many of our observations with respect to the provision of those services in countries. So that's the first illustration. The second is with respect to financial protection. And here we have three indicators that we're measuring. Is one, the catastrophic payments for the population as a whole, catastrophic payments for the poorest 40%, and impoverishing payments for the population as a whole. And you can see here that the coverage against catastrophic events is much lower than it is for impoverishment. And again, you'd expect that. Impoverishment is a much more dire consequence of paying out of pocket than having catastrophic expenditure. But you can also see an interesting trend, equity trend, which is that in many regions, 4 of the 6, the poor have lower coverage, meaning have higher catastrophic risk than the population as a whole. But that trend doesn't hold across all regions. So those are just 2 examples which give you a sense that, in fact, you can measure these 2 types of measures for UHC. So moving forward, in terms of global level monitoring, we've developed what would be a version of a potential goal, target, and indicator formulation, which is the way in which things get put into the post-2000 or the MDG in the post-2015 process. So the one goal would be reach UHC by 2030 in all countries, right? There would be 2 targets, that by 2030, at least 80% of the poorest 40% of the population have coverage to ensure access to essential health services. The other target would be by 2030, everyone, 100%, has coverage to protect them from financial risk so that no one is pushed into poverty or kept in poverty because of expenditure on health services. There would be 3 indicators of financial risk protection. One is impoverishing expenditure, which is an aggregate measure, a measure of the level of household impoverishment arising from out-of-pocket expenditures on health. This measure, we did not do an equity disaggregation because of the sentiment that impoverishment in any part of the population due to expenditure on health is equally important. For catastrophic expenditure, though, we have two indicators. One, the aggregate catastrophic expenditure, and also the catastrophic expenditure in the bottom 40%. And then those are the targets. And then we have 4 indicators of health service coverage. One is, 2 are for the MDGs, and 2 are for chronic conditions and injuries, and both are aggregate and equity measures of the service coverage, as we saw in the illustration. We want to finish by looking and emphasizing country monitoring, because the end of this is not to have global monitoring as an end in itself, but really to incentivize, catalyze country-level monitoring. And for that, we want to make sure that we remember that this is not a complete assessment of health systems performance. These are measures of coverage, right? Financial risk protection and service coverage, and not measures of health impact. And so we need to think of these in the larger family of indicators that would be used to measure health systems performance. Additional indicators of coverage and financial risk protection could be deployed in countries according to their data availability and their particular needs. Also, similarly, to employ equity stratifiers, which would be most relevant. And finally, to recognize that in order to monitor coverage, we need to remember that investments in monitoring systems are important. This relates to household survey capacity, as well as health facility data capacity. And those are the 2 primary axes through which these sorts of information that would allow you to measure these indicators are generated at country level. For further information, the discussion paper that's been handed out today is available on the web, on the WHO website, and there is information on where comments and feedback, suggestions can be sent at both WHO and the World Bank. Thank you very much.
Thank you, Tim. Thank you, Tiz. For discussants, we're fortunate to have 2 experts on the panel, and we'll hear first from Dr. Shin Young Soo.
Thank you. Thank you, William. Well, I'm regional director of the WHO, not expert, supposed to be, but I had some experience with these issues. I think no doubt that UHC become a globally shared vision, and now it is, as always, the core of the WHO's work. Our colleagues at headquarters, in collaboration with the World Bank, have been working on measurement framework and developing indicators for UHC, as you've been already presented here, and it is in still a developing stage. I think it is timely, especially in the context of post-2015 development agenda. And the suggestion from our colleagues is that measuring UHC progress should focus on financial protection and service coverage for key interventions and attention to access by the poor. I think this is a useful starting point for dialogue on development of UHC indicators. I personally strongly support the convictions that our President of the World Bank and Professor Takemi, that necessity of a good measurement indicators if we wanted to have a good UHC moving forward. I think we understand very well that this way that we can justify or investment and effort on these things without having these indicators and measurement, we're going to lose our kind of legitimacy or some kind of advocacy effort. However, I personally I have a problem that these indicators alone in this UHC do not tell us how we move forward for achieving UHC. I've been working with many member states in my regions, and then I just wanted to elaborate the complexity of these issues. That I think we must scrutinize that subsets of a lot of kind of indicators we considered, and then we have to maybe customize by country on their own political and social context. In the Western Pacific region of the WHO, we have been actively supporting member states on their journey to UHC for many years. Our conviction is that progress toward UHC is possible for every country, but the challenge is that the pathways so differ among countries. Although biological interventions such as communicable disease control programs can basically follow the same pathway with a predictable and measurable result, but UHC is fundamentally a social and political intervention. The journey to UHC has diverse starting points in each country and inevitably follow different routes. No single UHC measure can capture this, and countries will need multiple milestones. From yesterday's technical roundtable and this morning ministerial roundtable, we already heard that each country has taken different pathway and different points in approaching for the UHC. Immediate entry points may differ for each country, but if service delivery is to be improved, a systematic approach is needed to improve the functioning of health systems, as we have learned from Japan, Turkey, Brazil yesterday and this morning. All policymakers struggle to balance cost and quality in health system and to find the right set of financial mechanisms and to create sufficient infrastructure and capacity to meet health needs and regulate public and private sectors. But at the end of the day, it is improvement in service delivery, including quality of services, and that matters to people. I believe that UHC is a prerequisite to creating high-performance health system. We need services which are responsible to diverse needs of the countries, and we need good quality and comprehensive and accessible primary care, and we need safe and efficient hospitals. We need well-coordinated health systems and the financial resources that are spent well to ensure values at each step of the patient journey. To deliver such integrated and people-centered healthcare, we must align investment in health system infrastructure to ensure the health workers are appropriately trained and payment mechanism provide the right incentives, and our regulatory framework reinforces a good behavior. The information and monitoring system must provide critical feedback about whether the system is performing effectively or at least moving in the right direction. To monitor progress, we must have a minimum set of core indicators for UHC, not too many, not too heavy reporting burden for health workers. We also need to ensure that the basic information system provide reliable data. But UHC monitoring indicators ultimately must go beyond producing good quality data. The actors in health system and the broader public policy arena, including community groups, have to engage with the indicators and in creating meanings from this data and agree on priority actions. For indicators to have an impact on decision-making, we need transparent, accountable governance mechanism for health systems. Monitoring is process that involves whole of society, I believe. Ladies and gentlemen, I think the measuring progress toward UHC is very important indeed. More important, I think, is leadership with a vision and drive to focus on what needs to be done. Thank you.
Thank you. And another perspective now from Mark Pearson from OECD, please.
Great. Thank you very much, Bill. And thank you very much, Tees and Tim, for that fascinating presentation. Let me start with the easy stuff by talking about what I think about this twin-track approach to targeting measures of universal health coverage. I'm very enthusiastic. Do they reflect universal health coverage? Insofar as two indicators or two types of indicators alone can never reflect anything as complicated as universal health coverage, I think they're as good as we're going to get. Will they resonate politically? Can we imagine heads of state standing up saying that we are committed to ending impoverishment due to health? Well, yes, I think they work very well politically. Do they satisfy, and that's also in low and middle income countries, but also, I think, in donor countries, which is, of course, important. Do they satisfy the main characteristics that you want from indicators? Specific, measurable, actionable, realistic, tough, time-bound. And I think they do meet those criteria. So overall, I think you've done a fantastic piece of work to distill yourselves down to just these two types of indicators to summarize something as complex as universal health coverage. There are some details that I think you'll still need to work on. I do worry, for example, in the impoverishment indicator, how you're going to deal with aged care. As you know, for long-term care, often you find that public authorities appropriate nearly all the income of the person. Indeed, often they appropriate the assets of the person in return for the institutional care that they receive. At face value, it looks as if that's catastrophic expenditure and even impoverishing expenditure. And I don't believe it should be classified as that. I think there's perfectly reasonable case to be made on why you might want to finance long-term care in that way. I think there's also some issues to do with services, though here it's more to do with how hard a task I think you're setting the world with this 80-40 criteria. I mean, I was amused almost to find that one of the areas you were targeting was depression. Our best estimates in developed OECD countries is that between 30 to 50% of people with depression are even diagnosed, let alone treated, and you're targeting that 80% of the bottom 40% should be treated. Now, by no means am I criticizing you for that. Indeed, if you can make mental health be taken more seriously internationally, including in developed countries, you'll have done an enormous service. But boy, that's a hard ask that you're looking at. So I think overall this is a triumph of interagency cooperation. I can imagine how difficult it was to come up with this paper. And you certainly have OECD's full support, both politically in the battles that will be coming, but also I think in the implementation of these targets that you've identified. And let me just make 3 other points very briefly, because we are short of time, on the implementation of these targets. The first is that it seems to me we're going to have another push to develop systems of health accounts more systematically across low and middle income countries if we're going to manage to produce the sort of information that you need to monitor progress towards universal health coverage in the way that you have suggested. I think we'll need it for looking at impoverishment. I think we'll want it to look at progress towards service delivery, particularly if we can develop disease-specific health accounts. Of course, we have work to be done there. We've been working at it at the OECD level. We know that you've been working at it as well. I think we have to reinforce our interagency collaboration there to come up with some standards on disease-specific accounts, and we're very willing to put the resources into doing that. But more important, I think we have to sell this to low and middle income countries, because we clearly haven't done a good job so far. In developed countries, they're ubiquitous. Everybody is using health accounts because they know just how powerful a tool they can be for monitoring and governing your health system. But in low and middle income countries, they're too often seen just as a mechanism for resource tracking and not for actually governing the health system. I think we have loads of examples, some of which were mentioned yesterday from Turkey in catastrophic health spending, but there are other examples from Korea and the importance of identifying out-of-pocket spending, which have really driven policy changes for the better. And so we need to do better between ourselves in pushing systems of health accounts internationally. The second thing I'm going to mention about implementation of your approach is the closest I'm going to come to criticizing you without actually saying I'm criticizing you, which is your treatment of quality in all this. You know, some of the things that you talk about getting appropriate access for things like diabetes treatment. That's one of the cases that you look at. Again, even with a country like France, when we look at how many people are with diabetes are actually receiving treatment which follows clinical guidelines, and maybe it's between 40 and 50%. Now, I'm not saying that France is bad. By no means am I saying France is bad at diabetes care. The fact that it even monitors, and I can come up with a statistic like that, suggests something about how seriously they take the issue. But I think that shows that it's not just about talking about access to care. It really is about being able to say people are getting the right care. And I feel I would have been more comfortable with your paper and indeed your presentation if there'd been a little bit more on how you're actually going to monitor that the care that is being delivered is the appropriate care and not just the mere fact that it exists. In other words, I think quality needs to be part of the universal healthcare agenda. This is something that, of course, is going on. Certainly in my organization, we've been trying to develop indicators of quality for some time. We're now working with WPRO and CIRO regions to try and develop indicators of quality appropriate to those regions And we're hoping, of course, to have a global report with WHO on this issue in the coming years. Very briefly, because we really are running out of time now, the final issue I just want to mention is the importance of this case-by-case implementation. That's what we've been talking about for policy. I think it's also the case when we come to implementing the measurement of universal health coverage, even though we're talking about global indicators here. Countries will need support in developing appropriate health information systems in order to be able to monitor their progress towards universal health coverage, in the same way as they'll need support in developing appropriate payment systems, appropriate public management, appropriate management of the workforce. I think we need to integrate, therefore, support for the measurement and health information systems into our work on universal health coverage with countries, as well as on the development of policies. So in conclusion, full support from me on the principles of the indicators, with a little bit more work needed to tweak them. But I want to emphasize the importance of systems of health accounts to actually implement this as a realistic measure of universal health coverage. The importance of looking at quality as supporting information in measuring universal health coverage, and the importance of taking a case-by-case basis. In all of this, I think the OECD can help a lot, not least. We are the countries, the OECD is the countries where you have countries that have moved towards universal health coverage. They've made a lot of mistakes in doing that, both in their policies and in monitoring what they've done. It would be a terrible mistake if you don't learn from all the mistakes that have been developed across the world so far. Thank you.
Thank you, Mark. Well, a triumph of interagency cooperation. I'd like to open that comment and this presentation up to the floor, and I see two people already who'd like to respond.
Thank you very much. This is a remarkable achievement. But I'm wondering about two broad categories, how they fit in. Takemi-san made several times the point about the gap between aging and healthy elderly living, and the necessity to be measuring that gap, recognize it before it becomes such a big problem that your system is not easily adapted. And I don't really see that in here, in this framework. And the other comes from the space I work from, which is that I don't see a measurement of the resilience for catastrophic events. In other words, pandemics. I don't see surveillance for pandemic or epidemic outbreaks. I don't see the resilience to respond to, for example, pandemic influenza, or the resilience to respond to what we might call the big impacts of climate change, traumatic injury events on a massive scale, akin to the tsunami event Japan went through, or Typhoon Haiyan, or Hurricane Sandy in New York. So I'm wondering if you could perhaps elaborate how those two giant boxes fit in.
And we'll take a couple of questions before responding to these. In the back corner there, please.
Thank you, Chair. I'm Gishita from JICA. Well, especially as a country monitoring, possibly we might think that how healthy and attractive the health systems are. I know people know the bottlenecks of the health systems on the ground. Actually, informal payment, bribes, and also some unfair opportunities are exceeded by out-of-pocket payment. Also, immoral practice, vandalism, nepotism, also devaluate the significance of achieving universal health coverage. One of the Japanese lessons is that the people anyway although there is a debate, but the people anyway perceive the doctors and nurses, healthcare professionals at the summit of the morality in the society. That's why people are willing to pay for that, the premium. So vice versa, actually we might consider how we can measure the moral capital and the integrity of the health systems, which builds the promise of the health systems, and also engage more people to making efforts, joint effort to achieving universal health coverage. That is my concern. Thank you very much.
Thank you. I'm going to keep it with the 6 original questions that have gone up. I appreciate this is a very popular topic and it will overflow into the coffee break. But as we swing round the room from right to left, the last question that made it up early on the right was Professor Kagami.
Thank you. I have 2 issues that I want to put on the table. One is that you might consider thinking of who delivers the service. Is it a physician, a nurse, or a healthcare worker? And in some, I'm not saying that they should be delivered by a physician. On the contrary, I think in some situations, a physician should not be delivering that treatment or care. So that could be perhaps be made part of the matrix. So the second issue that I wanted to raise is that you were against disease-specific accounts, but once you, for the frail elderly population, disease-specific accounts would not be of much value. So it is the comprehensive geriatric care that is important. So this may go against your goal of having age-specific indicators. But on the other hand, I think if you do have these vertical programs focused on disease-specific accounts in an aging population, such as in Japan, this may not be appropriate.
Thank you. And there is a question towards the back here. Yes, please. The lady in the second row back. Thank you.
Okay, thank you. I have one question. I mean, ending poverty, extreme poverty by 2030, or zero financial risk by 2030. I think 2030 is, we have left only 15 years. It's not far. So we need a change, not only at country level, but at international level. My country believes that achieving universal health coverage is the main responsibility of the leadership of the country, the government, and its people. However, I think global leaders and global institutions has also a responsibility to support practically and to achieve the universal health coverage. Because we have to discuss the how part as well. And setting goals are wonderful. We had a universal health coverage what you call it, policy or whatever, internationally and nationally, for the last how many years? So it should be a joint effort, especially for developing countries, a joint effort and a joint accountability to achieve the universal health coverage. And my question is, do the global agencies and leaders are committed, or their supporters will be in line with this principle? Changing, it requires to change the aid architecture. honestly, my personal opinion, the current aid architecture is in favor of diseases, not in favor of people and society. So I do believe the main responsibilities and the critical change has to come by the government, by the political leaders and its people. We have a strong principle in Ethiopia. It's not only government. People should produce their own health, like agriculture, because we can't assign 80, 90 million health workers to each household or to each people. But still for the developing countries to achieve the targets of the universal health coverage, especially like zero financial risk and whatever, they need from the international agencies and leaders harmonized and in fact in line with this. So my question is there any room for post-2050 to change the aid architecture? So we might need at global level, high-level influential indicators. And regional level, a country level, we have to categorize all our indicators. I mean, I think it's not a problem in, not only in the country level. In country level, we always don't agree when we set an HMIS indicator, very few influential indicators, because each program people want to have a lot of list of indicators. And then we are struggling to have a small and maybe composite or tracer indicators. So why not we think to have a very small indicators at global level and let the country take care of the detailed indicators. So we have to see both two things. We have to take care of setting indicators at global level, and we have to also think the how part. If we say universal, it is universal. It requires more money. And then we are not asking additional money, but we are asking about the effectiveness and efficiency of aid. We shouldn't only focus on the country's financial management and the effectiveness, efficiency, but we have to look at global level aid architecture. Thank you so much.
Thank you. Ms. Brewer.
Thank you very much. This is a really, really useful and constructive step in the UHC movement, I think, to have some metrics. I'm going to be quick, but there are 3 questions. The first one's about principles. I'm sorry, I have to ask them. The first one's a principle-led question, and it kind of is a bit different from Mark's approach to this. It's not about feasibility per se. But if universal health coverage is fundamentally about equity because it's universal, why are our service coverage indicators only about 80% in the bottom 40%? Why aren't they about 100% in all segments of society, which goes beyond just the economic stratified to look at different criteria of equity? First question. Second is, we heard from, a lesson from the MDGs was that there are important pathways towards progress on our goals. And the health system strengthening agenda is one of those major lessons to avoid over-verticalization. In light of that, is there, I know that the Sustainable Development Solutions Network has proposed some interesting additions to the thinking that you've done, I think, on other health system outputs. For instance, the Human Resources for Health metric. There may not be the perfect one existing now, but maybe this is an opportunity to find one. Similarly, policy guidance on health financing, public versus private. It's been a big theme of this meeting, so why isn't it there? I would echo the point of the Ethiopian speaker to say that international social solidarity for health financing is an important component too. The third quick question is, what was the thinking behind the risks of aggregating service coverage indicators? Because they will no doubt hide areas of strength and weakness. And how will we manage that? Thank you.
Thank you. And the final question from Dr. Cooney, please.
Thank you, Chair. I'm Sam from Global Fund. Just comment. this common framework of the monitoring evaluation and also action plan is very important. And at the time, we find that the kind of fragmentation of monitoring and evaluation, even Global Fund just asks that many countries for very the volume of the indicators. But I just want to give some good evaluation, because working with WHO and World Bank and others, we are trying to have a quite comprehensive impact review and also AP data kind of things, and also trying to reduce the indicators more impact-based, so that we are now reducing around 30% of indicators toward that impact. So, and also we have a quite good comprehensive review, like Thies and I myself just visited Tanzania recently, and we had a kind of a comprehensive review of data before the midterm review of the Tanzania. It is a very good kind of indication, because they review that the quality of data and others of all chronic disease and the mother and child health and the disease one. So such kind of the country level and global level, the coordination of monitoring and evaluation, very important. And we also have to look at kind of capacity of community health workers and whatever, that what kind of the burden they can just get, so that we can give a very efficient type of the way of the monitoring and evaluation. And finally, I also want to say that we are also working for the result-based financing, so that we can also reduce and just focus on the impact indicators for the performance. Thanks.
Thank you. I'm going to have to ask everybody else with comments and observations on this to please submit them to the email address on the form. But if we could quickly move across the table to find out how these important points actually change thinking. So starting with Tim, please.
Actually, in the spirit of collaboration, I get to start this time and then leave all the hard questions to Tim. Just on the comment by Mark about the quality indicators, I think that's a very crucial point, and the way OECD is handling that, it uses the coverage indicators and then has additional, like survival on cancer treatment and so on, which is very difficult in terms of comparative value. Diabetes is actually a good example where we all could do better, because in a survey, one could actually measure how well the treatment is doing by, for instance, an HbA1c test. The same with vision, the same with hypertension. One can measure the blood pressure, and then we get effective coverage of the treatment. So that's important, and I think more work is needed in that area. The second, a comment that is made by many is around, well, this is a fairly narrow set of indicators, and the view needs to be on the health system as a whole, which we agree is a very valid point. So this is only the monitoring of coverage of interventions and financial risk protection, which of course needs to be completed, embedded in a country system of monitoring health progress and performance linked to the National Health Plan, for which there is a national system of monitoring and reviews, for which there are indicators which go well beyond these universal health coverage related indicators. So I think it's very important to embed it in that overall framework, and I think we should actually add it to this paper. The issue of aggregation is also very important, because that's do we lose the value of the individual indicators when we aggregate? And I think while we aggregate, we should always present in a clever way the individual indicators, because there are huge differences in different intervention areas. So that's a valid point. Why at least 80% as a target, at least 80% among the bottom 40%? I think that's obviously the aspiration is everybody, 100%, but it's based on a sort of realistic approach, which I think, again, Mark illustrated when he talked about depression in OECD countries or many other indicators. At the moment, that even in countries where we say there is universal health coverage, that's what the situation is. If we can really measure the need in the population, not everybody's got what they need. So I think at least 80% is a realistic target.
Great. I just want to jump in on that to support Thies, on one other dimension of the measure, which is it is relevant to all countries. If you use measures like this, there isn't a country in the world that will have achieved universal health coverage. And I think that gives some humility to Bill Shao's point, which is insurance, universal health insurance is not the same as universal health care coverage. And I think this really draws attention to the fact that coverage for a lot of very important preventable conditions is extremely low or unacceptably low in even the richest societies. I want to pick up on a couple of other points. First, Lori made a very important point that these measures don't really pick up on the issues related to surveillance for pandemic preparedness, emergencies, and disasters. And in Turkey, at a meeting on universal health coverage in July of this year, there was a very interesting panel on universal health coverage in emergencies. And I think that this is an area where we have to put it on the agenda of what I would call progressive realization, which is these measures that we're suggesting be measured really don't get at coverage for emergencies in those humanitarian emergencies, those outbreak situations. And I think as a further step in the development of measures, we need to put that on the agenda, which is how do we measure coverage in those acute emergency situations. And I'm glad you flagged it. I think it is a very important agenda for development. Hopefully you've got some good solutions. With respect to aging and the elderly, I think that the idea of this chronic conditions and injuries is that we explicitly do embrace the elderly as part of the population where those conditions are important and coverage of services are important. I think Bill's, the earlier comments from Mark on the issues related to financial protection in that elderly group are ones that we need to do some more thinking about. In terms of the issue of joint accountability, the design of these measures are done very explicitly with respect to that post-2015 development framework. And so I think what we are saying is that these are things that the global development partners need to take on as areas of interest and concern. Now, we all know that that's a negotiation and one that has many dimensions, but our feeling is that if these targets, indicators and targets get into that framework, then that will help, for example, bring attention, much more attention to the issue of financial protection, which has thus far really not made it onto the priority agenda. The other thing I can say, and this is sitting on the boards of the Global Fund and Gavi, the discourse around those tables now is increasingly looking at sustainability solutions, which is bringing attention to domestic financing arrangements and exit strategies over time. And I think that those discussions are very timely in this regard because I think these indicators will be helpful with respect to that agenda. So I think I'll stop there and hand it back to Bill.
Very, very briefly, I just want to emphasize, I mean, a lot of these comments were implying that we can do better in measuring universal health coverage if only we could add some other dimensions. And I'm sure that's true, but the objective of this should not be to measure universal health coverage. It should be to make sure that universal health coverage is on the international agenda and we make progress towards achieving it. That means every indicator that you add to the list, you detract from their impact because you will lose the attention of leaders. The achievement of this paper, and for all the little tweaks that I would like to see in improving it, nevertheless, the major achievements of this paper is to come up with something credible which looks like universal health coverage in 2 indicators. It's fantastic.
Very briefly, obviously, we agree on this overarching 2 major measurement and indicator development, but still, when it goes to each country level, I think we have to develop and process all these different level of indicators with agreement, customize their own, and this is more on a country progress monitoring process. And second one is that we had some difficulty in MDG target and goal measurement. I think we have to develop more reliable information system and capacity development in each countries. And also, I think we have to, this matter is very much in financial issues involved. The accounting system has to be standardized and developed properly. Thank you.
Well, thank you very much, Tim and Thies. You have given us a presentation which will generate much reflection. It will change the way we think about universal health coverage in the future, about the ways that further meetings discuss progress. So thank you very much for your work on that. Thank you to the discussants for their insight, and thank you to everyone for being so patient. A brief tea break follows.
We will just take a brief break, so about 10 minutes, and they've set up coffee and tea in 2 separate places, so hopefully it'll be easier for all of you to get to what you need. Thank you.